So my lecture is on Sphenopalatine Ganglion block. I hope my slides are visible to everyone. And I'm Dr. Sairah. So I will be briefly discussing the introduction, indications, anatomy, different methods to perform the block, complications related with the block, and that will be followed by some videos. Sphenopalatine block, it is a procedure that involves administration of local anesthetic to sphenopalatine ganglion that lies in the pterygopalatine fossa. So let's have a look on the outer anatomy. This is pterygopalatine fossa. As you can see, my cursor is here. And this is the red star. This is the sphenopalatine ganglion. Just appears to be sphenopalatine ganglion. So sphenopalatine ganglion is bounded anteriorly by the maxilla, this one, and posteriorly by the greater wing of sphenoid bone, and medially by the palatine bone. And there are fissures, as you can see here, my cursor, and then there are different foramina. The ganglion communicates with the neuronal and vascular structures and other structures in the face through these fissures and foramina. Now just have another look from inside. How does the sphenopalatine ganglion look from inside? So this is the inside of a human nose, the nostrils, this is a lateral wall, this is the posterior side, and this is sphenopalatine ganglion. And like over here, sphenopalatine ganglion is covered with very thin mucosa and thin connective tissue. And as you can see, its branches going out from here to the nasal mucosa and to the palatine mucosa. Yes, sphenopalatine ganglion lies in the posterolateral nasal wall and it covers with a thin mucosa and connective tissue. And from here, it gives off branches and also receive branches from the important structures. Now let's have a look into the what branches it receives and what branches it gives off. So it's a cluster of nerve cells that contains both sensory and autonomic nerve fibers and is 5 mm in size. It's an autonomic ganglion, mostly parasympathetic ganglion, and it regulates nasal and lacrimal secretions through autonomic nervous system. First of all, parasympathetic fibers. Sympathetic fibers here are indicated in the blue. Preganglionic fibers reach SPGs, sphenopalatine ganglion, through facial nerve and through the branch that is greater petrosal nerve. The postganglionic fibers, parasympathetic fibers, then arise from here and get distributed to the lacrimal gland, to nasal mucosa, and the palatine mucosa. Like as you can see here, let me use my marker. So these are the preganglionic fibers coming from here. This is a location of the SPG. From here, as you can see, the fibers, the postganglionic nerve fibers are going to the lacrimal glands, to nasal mucosa, and over here going down into the palatine mucosa. And then it also sends branches to the meningeal blood vessels, like over here. Sympathetic fibers are indicated with pink color. Fibers originate in the superior cervical ganglion and they pass through, and they just pass through it without even relaying here. And they innervate the same target tissue as the parasympathetic fibers. Sensory fibers are demarcated as yellow. Sensory fibers from palate, oral cavity, tonsils, and uvula pass through SPG and join the maxillary nerve over here. And the fun fact about the sensory fibers that ice cream headache and anything that causes brain freeze, like anything like when you take something cold, is mediated by SPG. Now, after, as you know about the anatomy of the SPG and the branches it receives and the branches it gives off, now you can easily understand the indications of this block. First of all, the very common indication or the important indication is the trigeminal autonomic cephalalgia. So what is trigeminal autonomic cephalalgia, also known as TAC? It's a group of headaches that involve trigeminal autonomic reflex pain activation system, and the one example or one type is cluster headache. It's mainly autonomic in nature, and the mostly parasympathetic component is involved. And aside from cluster headache, it is effective in migraines and post-dural puncture headache. And in the facial pain, mostly that may involve sensory branches of the maxillary nerve or any autonomic component involved. As I have already mentioned in the anatomy, there's that the SPG, it lies in close proximation to the maxillary nerve. Mechanism of action of pain relief. How does it relieve the pain? The SPG block. Now, SPG block constricts the blood vessels in the brain, which can be beneficial for migraines and other conditions. It also interrupts the trigeminal autonomic reflex. The SPG block can interrupt the trigeminal autonomic reflex, especially the parasympathetic component, which plays a role in the cluster headaches. Pain relief, the local anesthetic we give to block SPG, it blocks the nerve signals, reduces pain and inflammation. That is, for example, in case of maxillary nerve involvement. Now, SPG block preparation and techniques. Okay, so about the equipment and patient preparation, the necessary supplies, as you can see here, is very simple and basic setup you need for it. The Q-tips, gauze, local anesthetic. Sometimes you might need a syringe and sometimes not. And then over here in the patient preparation, ensure the patient is informed about the procedure, assess medical history, confirm allergies, and obtain consent to promote safety. Now there are different methods to perform SPG block, non-invasive and invasive. And the first two are non-invasive, and third and fourth methods are invasive approaches. So these are basically, you can also name them as topical approach or intranasal approach, while the third one is ultrasound guided and fourth one is fluoroscopic guided approach. In this lecture, I will discuss and demonstrate method 1 and method 2 for you all because of the ease of performance and convenience. Now first, this is method 1, in which very self-explanatory pictures. All you need is a syringe with a small nasal catheter attached to the syringe, and patient should be in supine and sniffing position. First of all, take lidocaine 4% solution in a 5 ml syringe. You can also take bupivacaine as you wish. Slowly drip drop by drop from the syringe into each nostril. You just have to make sure that that your catheter is the length of the catheter is maximally inside the nostril along the bridge of the nose, so that when you will inject the drug through the catheter, the soft catheter, it's not a needle, it's a catheter, so it will trickle down from here to here because of the gravity and patient's position. So this is the site where on the superior and posterior edge of the maxillary, the medial turbinate, where lies the SPG, like over here. Let me use the marker. So this is the location where SPG is located. So what you have to do after, okay, keep dripping until the patient feels the bitter taste in the throat, and keep the patient in position for 15 minutes. If the cause of headache was post-dural puncture headache, then patient is asked to briefly sit up. If the headache is not sufficiently relieved, then this procedure is repeated 2 more times. Volume requirement is about 0.5 to 1.5 ml of medication. Just to keep it under a safe dose. Now, second method, Intranasal approach. Again, the self-explanatory pictures. All you need is Q-tips, and they're also known as the swab culture sticks. Take a Q-tip, it's hollow inside, cut off the red cap from Q-tip, take a blunted 18 gauge needle, drop 1 to 2 mL of bupivacaine, thread the blunted needle onto the Q-tip, dip the cotton end of the Q-tip into 2% of or 4% of viscous lidocaine. Now, just appreciate that, like on the tip, or the cotton side of the Q-tip is it's soaked in xylocaine, while inside the syringe there is bupivacaine. So, about the Q-tip insertion, a Q-tip insertion should be parallel to the zygoma, like over here, like this, in this direction. Insert the Q-tip in this direction, just like this. So while the patient is lying supine and in the sniffing position, gently insert the Q-tip straight into one of the nostril until resistance is met. You have reached the posterior superior side edge of the middle nasal turbinate, and do not push against the resistance. Inject the bupivacaine through the Q-tip. Now remove the syringe and needle, keep the Q-tip in place for 10 to 15 minutes. After 10 to 15 minutes, remove Q-tip. If patient experiences hemifacial pain relief, that's good. Repeat the same on the other side. Now I have 2 videos for you. I hope it's clear. I can replay it for you again. So when you insert the Q-tip, it goes directly to the posterior end of the medial turbinate. Just like that, and leave it here for 5 to 10 minutes. We have another one that is more that has more elaboration for understanding. So it was so simple, so easy. So these are different non-invasive, easiest methods, easiest techniques for the understanding purpose. I hope I think most of you have now understand and just know the technique how to perform SPG block. Just with a syringe, Q-tip, or sometime you may need a soft catheter. You can also use three-way tubing, short tubing along with the nasal catheter or with the syringe. So how block works, the local anesthetic is delivered to the mucosa underlying, that is overlying the sphenopalatine ganglion, leading to transmucosal diffusion of local anesthetic to sphenopalatine ganglion and its mixed sensory and autonomic fibers. Limitations where it does not work. It works in PDPH and TSAs, but sometimes the pain relief can be surprisingly quick, but often temporary, sometimes lasting hours, sometimes days. Some patients may need repeated applications. Now in about the maxillary nerve block, it's palate, posterior nasal cavity, nasopharynx, sensory fibers, like the sensory supply of the maxillary nerve. So it's unlikely to get complete anesthesia of the infraorbital zygomatic or upper dental nerve. Those would need a direct maxillary nerve or infrazygomatic block. And the effect is strongest in the palatine, posterior nasal region, and weakest in the skin of the midface and anterior teeth. So, like it can help in some trigeminal neuralgias, like as well, but it is not the first line or most reliable method. So, and yes, I also want to say something here. Like, do not confuse trigeminal neuralgia with TSCs. TSC is trigeminal autonomic cephalalgias. That is a different thing, and trigeminal neuralgia is a different thing. I haven't shared the details because the details of all the headaches will be in next lecture by Dr. Umar. So contraindication and side effects, contraindications, absolute and relative contraindications, patient refusal, local anesthetic allergy, then active local infection, sinus trauma or surgery, coagulopathy, anticoagulation, because epistaxis can result, deviated septum. Side effects, bitterness in the throat, temporary soreness, mild nasal bleed, dizziness, numbness in the throat, low blood pressure, nausea, and rare allergic reaction, and sometimes partial maxillary nerve block because of in the close proximation of the two. That is my last slide, short-term and long-term follow-up. Its short-term results are very good, like in 70 to 90% of the patients, there's instant pain relief. In the long-term follow-up, it is also has promising results. Studies show that the sustained pain relief success rates are good, and it can go beyond months. Now, what is the future of SPG? SPG is the new indication, exploring the SPG block for new indications such as treatment-resistant migraines, anxiety disorders, and sinusitis may expand its clinical use. And there are reports about its efficacy for intraoperative analgesic effects for palatoplasty and FES surgeries. So that's all from my side.